Hello everyone and welcome back. I'm back with my very good friend Papa Berko, who will be throwing light on his experience as a first year resident, specifically as an IMG, starting his rotation. Is he with ICU or floor?
Yeah, ICU.
With ICU, so kindly listen to his challenges and learn a thing or two from it. So tell me, first day at ICU.
I don't know how to start. That was like a baptism of fire. I mean, how do you feel entering a whole new environment, not knowing what you're looking at, not even understanding what you hear, and not knowing where to go and what to do? Right?
Yeah.
That is exactly what I went through.
But there was an ICU at Suhum Government Hospital where you worked.
No, there was nothing like that.
Okay.
That was just a recovery, but there was no ICU. So just being thrown into a new place, a whole new system with a whole new way of doing things, and then this ultra modern ICU with all the cut throat machines and equipment and everything you read in books, staring right in front of you.
The mechanical ventilators beeping and you don't know what to touch, what to press. You are scared to.
You're even scared to talk. At that point, you lose your voice because you don't even know what is happening, right? You're so intimidated. That's exactly what I went through. You know,
Right. Okay.
it was a steep learning curve. I had to maneuver my way around.
And how many patients did you get to see on your first day in the ICU?
4, just 4 patients. But then again, before moving here, I had like the maximum number of patients you'll see is like 8, and then having known that I was seeing like more than 40, 50 a day back home, I'm like,
You're like,
it's just 8 patients. Like, what can happen?
Yeah. But at the end of the day, you realize that the 8 patient takes the whole day to be seen.
You may not even finish, but you have to finish because of the amount of work that goes into one patient. It is unimaginable.
Yeah.
I mean,
I'm sure our listeners will be wondering, like you were back then when you were in Ghana, that what really goes into seeing these 8 patients. It's just 8 patients. So what really goes into seeing 8 patients that you may end up spending the whole day still working on this 8 patients? So we'll take our time and break it down as to what you are expected to do as a first year resident, as a second year resident, and maybe PGY3, that's a third year resident. What the attendants do, one may wonder if they are sitting somewhere, not really doing anything. So we'll take our time and go through that. But what Beku has been telling us so far is that moving from Suhum to Piedmont, seeing the whole infrastructure and the resources were so overwhelming.
It's intimidating.
He lost his voice. So were you able to interact with the nurses?
You wouldn't even know how to do it because it's just so scary. Like it's not as if you don't know what to say or know how to talk. It's just that everything all at once is just so intimidating. You know, you can talk to them, but then again, you are scared. It's like you lose the assurance, or that confidence you have.
Confidence you
lose the confidence. I mean, within the first 2-3 months, you lose it.
Meanwhile, back at home, you were leading a team of.
Meanwhile, I was doing almost everything back at home.
Yeah.
You know, so that transition was just.
And let's talk about what time did you get to work, or when you are on the floors, when you are at the ICU. What time did you wake up? What time did you get to work? What time are you expected to be at work?
So usually you're expected to be at work by 6 o'clock, right? But for someone who does not know anything,
in your own interest,
you need to get to work way before 6. Not way before, but like I got to work around 5 my first day, just so I could see the patient. So what happens is that as an intern, you have to see your patient. You're given a number of patients to see every morning. You see your patient, and then you pre-round with your PGY2 or PGY3. Then you have your ward rounds where you roundly attending, and and that is what I was expected to do. Now, I come in my very first day, had no idea what an EMR is, the Epic software.
What does EMR stand for?
Electronic medical record.
Okay.
Right? And it is a robust healthcare software where you can.
You can get lost. It's like a forest that you can.
Yes.
Yeah.
It is robust, and if you have no idea what it is, you don't even know how to first pre-chart. Pre-chart means like going through the patient's file, right? It's like a file on the PC, right? And then finding out what happened overnight, finding out whether any new events, looking at their lab work, and then formulating a plan for the day for the patient, right?
Okay.
And that alone in itself is a lot of work. I mean, for an intern, it's a lot of work because number one, you don't even know where to look, what to look for. Right?
Now, what at all could happen overnight that is so much that's like you can't just go and look at and spend, let's say, a minute or two to tell.
No, you have to look because everything is important. Everything is important, right? Perhaps the patient had a VTAC. It's important. It will be important to the management, right? You have to look at electrolytes, look at too many other things, read notes from the previous day, read notes from the night team, all of that, like culminate into the management of this patient, like along the line during the day. So all of that is important, and it's something you have to know and do, right? And so you have to do it, and you have no idea where to go, to what to look for. For in my case, for example, my very first morning, I went into this patient's room. I had to examine this patient. I was so scared. Like, you hear about all those lawsuits and the American stuff and all of that. You're so scared to touch the patient. you don't even know what to be looking out for. Ventilator settings. You have absolutely no idea.
Yeah.
Right. That is very, very intimidating. You leave the patient's room, questioning yourself and questioning all that you know. You see, then you're done with that. You have to pre-round with your second year, and it is just so different.
Wait, so you pre-chat by yourself?
Yes, you pre-chat
without your second year or your PGY 3 being involved.
Mm-hmm.
Then you spend an extra time to go and pre-round with your senior. So when will the attending come in?
So the attending comes in during the normal rounds.
Oh, so that's actually a 3-phase.
Yes, you have the
process.
3-phase process, and that is a lot. So just imagine the intern presenting to the PGY2, and then sometimes in the PGY3, and then you go and present to the attending in a space of about an hour or something like that. That's a lot of work on the intern.
Yeah. So, well, Beppo is saying it's quite very significant. Usually, you may think you have time by your side. He got to work at 5 a.m., but after a blink of an eye, you realize that it's almost 7 a.m. and you actually sometimes have to go and take a sign out.
Oh yeah.
From the night team.
From the night team.
And that's actually precedes the pre-rounding.
Yeah,
So
that's true.
you have to make time to take sign out from the night team because they will have admitted patients overnight that you have to take over. Sometimes, if you are not fortunate, you'll be the one seeing those patients and then quickly pre-chat on those patients. The most important thing as to why they are admitted and what needs to be done for them.
Mm-hmm.
Then you go and pre-round with your PGY2 or PGY3. Together as residents, you formulate a plan ready to be discussed with your attending. That's a lot.
That's a lot.
Yeah.
That's a lot.
So let's still dwell on your first day. You saw about 4 patients.
Yeah, 4 patients.
You got to work around 5 a.m.
Mm-hmm.
Around what time were you ready to pre-round with your senior?
I was never ready.
You were actually not ready.
I was not ready. I was not done. I couldn't finish
So-
because there were so many things. I kept going into check and going out. It's true. Because I mean, I would think I'm done, and then the PGY would ask me, "Have you checked this?" I'm like, "Oh, no, I haven't checked. I'll go and check." There's so many new things I had to understand at that point.
There was a lot going on.
Tube feeding. I didn't know what tube feeding is.
Yeah.
Right, and then I'll be asked, what goal do you?
Is the tube feed at goal? What rate of tube feed is the patient on? Yeah, so there were a lot that you left out that you need to go back and forth to.
Figure out and all of that. Yeah, so it was a lot. I did not finish my first day.
So that sounds like a hallmark of the first day of an IMG, from what I'm hearing. You will never be ready the first day. I mean, at a point, and everyone actually understands. That's the good part to it. Your attending is aware and prepared to spend some time on rounds. They are actually psychologically prepared, knowing that it's July. They call it the July season, knowing that there will be interns that needs a lot of guidance.
Yeah.
So everyone is actually ready for your inadequacies or inefficiencies.
But the thing is that because you're not even ready with pre-charting, it's a big blow on your own confidence, right?
Yeah.
A big blow on your own confidence. And then even during the first pre-rounding with the seniors, the amount of information they give you alone
it's too much.
It's too much
to recall and present
the way they want
such,
the way they want you to. So you head into world rounds trembling, like you are fearful because it's like, will I remember what I was taught to say? Do I even understand what I'm going to say? And so it's just a lot of fear, intimidation, and it's like a vicious cycle that keeps going. Because if you're presenting and you say something really wrong, then everybody's like, what are you trying to say? It just keeps breaking your spirit and
it's your confidence.
And it's like that. It's expected. I mean, at that point, I didn't know it was expected.
You wouldn't know that it's expected, and that's what makes it difficult. Because, I mean, looking back, when you get to a comfortable position, you look back and realize that okay, so it was actually expected, and it gets better. But at the time where you are in a mess, at the time where you started and it's been difficult for you, I mean, even seniors will tell you that, oh, come on, it gets better, but you yourself, like, you realize that no, a lot is going on. Yeah. And it happens to all of us. And I kept telling you back then when you were in Ghana that, Sally, it's not going well.
And I'll be like,
I'm sure you were like, I was like, what exactly is it that is not going well? So until you experience it, you may not be able to relate with it, but we just want to prompt you so that when it gets to that point where you feel like all hope is gone or all hope is lost, you recall this episode and realize that, hey, these guys have been through it and it's actually expected.
And when you're going through it and you feel like all hope is lost, just know that it's just the beginning.
Yeah.
Like, it gets better.
It actually gets better. So you were, I mean, what time did you get to finish rounds on the first day?
Like about, so usually we finish rounds around 11:30, then we have to go for
noon conference. Okay.
So by 11:30 we were done. And when we were done, I was just so relieved because I was just mesmerized. The amount of information that was hitting me. I realized that every single thing you say is supposed to be evidence-based, right? And so that even makes you even less confident because you don't even believe in what you know anymore. Because everything you say has to have a backing, has to have some trial backing, something backing it,
Yeah.
And so it's just kind of, then you realize that you really, really, really don't know anything. Even if you had a 2H1 USMLE, translating it into clinical context is
totally different.
Totally different ballgame altogether. So then,
okay. So this is how I like to look at it. So when you start residency, there are three components of experience that you end up facing. Or challenges. So we have the system-based challenge, which Beku is alluding to, like the electronic medical record. There is the medical knowledge that's like the 280, at least you have some fundamental medical knowledge. But the practical component of that knowledge, how you translate that knowledge into what is being practiced, is totally different. So, as an IMG, you have the challenge with the system-based practice, and most likely the practical.
Oh yeah, most likely you will. I mean, you will, because even if you know certain things, how to even voice it out to make it make sense is also a problem. Because they like you to say it in a certain way, they like you to express yourself in a certain way, and it's not all about the USMLE step 1, step 2 stuff. There are so many things that are happening.
There are lots. Things are changing daily. Trials are coming out. Guidelines are being modified.
So you just need to, and you realize that you are just inadequate. You just know you're inadequate. I mean, So that was also something that I had to.
But someone will say that I'm done with my. We have people in our program and elsewhere in other programs who completed their residencies in their home countries, and they still feel that inadequacy or not ready. How would you explain that?
Number one, I would say the big one is system-based practice. Second one is even communication, because even sometimes you will talk and then it's like you're not making sense to people because they don't even understand your accent and all of that. That's number 2. Number 3, medical knowledge is medical knowledge. I know that people have completed residency and all of that, but when it's right in front of you like that, right, with the resources you have, right, that even poses a challenge to you yourself, because you won't be able to believe that right in front of you you can order what have I even ordered? Cryptococcal antigen, right? Yeah. And get the results in a few moments.
Just think of any lab that Adam TS13, which will take days to come, but like you still go ahead and order it. Yeah.
These things.
Serotonin assay for heparin-induced thrombosis. Like, there are things that you think they are just
textbook, but it's right in front of you. Yeah. You can order the lab and get it done. So these things, even seeing them alone is like shocking. Seeing them right in front of you alone is shocking. It's intimidating, And so
So the resources you have defines how you practice, and perhaps from your home country, although you are probably a specialist or into a residency or completed residency, because you do not have access to those resources and they are not the daily routine practice you are exposed to. You come here, and because things are done differently, you are not accustomed or used to it, and the fact that your confidence to start with is low, it's enough to kill your vim. Like, you may have the knowledge in your head, you may have all the information theoretically, but the way things are done, the pace, everything, like, you are just inadequate to start with, and you must accept it from day one that, hey, I'm here to learn, I'm here as a PGY1. Even there was a neurosurgeon who used to be in our program and completed. We didn't come to meet him, but I mean, I understand every single one of them face the same challenge, and it's just the way it is. The US medical system is totally different, and you should be ready when you start. And I now understand. It was when we started that I understood why they were very focused on having UX clinical experience as part of the requirement. So if you can talk about it, like,
honestly, I even had some US clinical experience, but I know they see top.
So you can imagine
not having any experience at all. I mean,
because during the interview process, when like they ask, do you have any US medical I'm like, what exactly are you talking about? I've been practicing in Ghana for so many years. Medicine is universal.
Is it?
Medicine is universal. Why are you asking me whether I have US clinical experience? But when you hit the ground, you realize that they know what they are doing. That's the way I'll put it. So I think we need to take time and make a video on how to pre-chat. We'll use the electronic medical record that we use here, which is EPIC. It's universally used in the US, and I'm sure a lot of residency programs use that's electronic medical record. So we'll do a video on that and demonstrate how you need to pre-chat, because trust me, you need to have a system when you are pre-chatting, and you must stick to it. I mean, it will be haphazard at the initial phase, but when you're able to have your own system in place, it makes things easier for you.
Yeah.
So we'll make a video on how to pre-chat, things you need to do before pre-rounding with your senior. If you can just start briefly on it, but I think we'll need to make a separate video on that. So now that you are in a comfortable position and can now pre-chat and pre-round, before you meet your senior to discuss or to pre-round, how do you go about it? I'm sure they'll be interested in knowing.
Yeah, so everybody has his own style.
Yeah.
Right? But as for me, the very first thing I do is that I epic chat all the nurses. So all my 8 patients are epic.
What's epic chat?
So it's a way to send a message to staff.
So secure message to the chat through the electronic medical record. Okay.
Yeah, so I epic chat the nurses, find out what happened overnight.
Okay.
And then I go to the patients.
Okay. Could you have gone to the bedside as well to ask them the same question?
Yeah, you can do that. But then again, to me, I think it wastes. It just makes the whole process long.
Okay.
Because some of them can just talk and say out unnecessary things. I mean, things that are not supposed to be. Are not
relevant to you at that point in
time.
So
I just ask them what happened overnight. Sometimes when I meet them at the bedside, so I ask again. But then again, after doing it, I have an idea what happened overnight.
Okay.
Then I go through the patient's chats, look at overnight events, if there was any note from the night team, right? And then usually I set my labs for like 5 a.m. And so by 6 a.m., the new labs for the day would have been out.
Okay.
And so I take a look at the labs, see where there are any derangements. Then I apply that in the context of the pathology I'm managing to see whether it's relevant or not.
Okay.
Then I have an idea. Then I go to the patient at bedside, and then I ask the patient questions relevant to the pathology or any other new developments.
So when you start your day, you do not start by rushing into the patient room. You sit down, see what happened overnight, look at labs, that's if they are ready or not. Send a message to the nurses because they have been with the patients overnight and have more information to tell you. And then you move to the patient bedside and see the patient.
Yeah.
So whilst you are going to the patient bedside, you at least have an overview of what has happened overnight. Okay.
All right. Questions to ask.
Okay.
And relevant information to get out of.
I think what other people do is sometimes, it's a big hospital. Your patient will be at different blocks, and we'll talk about navigating one block to another or moving from one patient's room to another, where maybe patient A is in room 6321, patient B that you are seeing is in room 4322. That will be maybe ICU. How you structure which patient you see first, second, which patient is the sickest, all those things are kind of very complicated because you don't want to be ready to precept with your second year where, let's say, you have 1 or 2 patients to see, and the one that you are not ready to talk about is actually the sickest. So we'll get into the nuances of that, but what Beck is saying is that he goes to the computer, open Epic, which is the electronic medical record, check relevant overnight notes or overnight events, which may be in the form of a note from the night team, look at labs to see if they are ready, send a message to the nurses to see what's happened overnight or if they have any concern, which is actually an information center. The nurse's message can actually clue you into what you need to do for your patient and what you need to say during rounds to actually advocate for your patient. So that's very important. And then you go and see your patient, then come back, reconcile your examination finding, what the patient tells you, and that will lead us into a different component called the SOAP format, which we'll talk about later. So now let's assume you've gone to see your first patient.
Mm-hmm.
In the patient room, what happens in the patient room?
Right. So the patient room. Okay. So it depends, right? Some patients are stable. You've gotten information that there were no overnight events. Labs have been pretty much stable, and generally that this patient is stable. You enter the patient when this patient is fast asleep. What do you want to wake the patient up?
Good question. You don't want to wake up that patient, and if he or she begins talking, it will take your whole time.
Yes.
So that's actually, should I say, a pill there that you need to pick. Patients that are very stable, in fact, see them last when they are sleeping. Do not wake them up, because when they begin to talk and they want to talk about their problems that are not urgent, it's very difficult to catch them. It's very difficult to excuse yourself. So please just walk away and come back to see the patient later. Your senior will understand.
Everybody understands.
Your attending will understand. Everyone knows that your patient is stable. This is something I didn't know. I will find a way to wake them up, and when they start talking, then in my head I'll be like, oh God, what have I done to myself?
Yeah.
So thanks for bringing that up. Okay, so I won't wake that patient up. I'll move. In fact, I won't start by seeing that patient.
Yeah.
I'll see the sickest patient first. Okay. So let's assume you are in the room of your sickest patient.
Yeah. So in the room of the sickest patient, you want to look at vitals, right? First thing I always want to do is look at the monitor, look at the vitals, look at the pulse rate, O2 saturations. If this patient is on oxygen, you want to check how much oxygen this patient is on, right? You want to make sure that what you saw in
the chart,
on the chart,
whilst we are pre-charting,
corresponds to what you're seeing. Then you take a step back. You tell the patient, if the patient is awake, you ask for permission to switch on the lights, right? Then you turn the lights on. Then you take a step back, and then you greet the patient and go like, oh hey, I am Dr. Berko. I'm going to be your doctor for today. If the patient is new, if the patient knows you already, you just, hey, how are you doing? And the patient talks to you. And then you just tell the patient that, oh, you're just here to examine him, and then find out whether there's any new problems he's faced overnight, or whether he has any new complaints, right? So what I do is that after doing that, after talking to this patient, I take a step back and just look at the patient. I look at how this patient is breathing. Just look whether this patient looks worse than he was yesterday, or is looking the same. Then I ask questions, and then I examine the patient. You wouldn't want to spend 15 minutes examining patient. So you want to...
You actually have 5 minutes in that room.
Yes.
And we'll talk about the challenge of spending less time with patient, which is actually something unique to this system in quotes, and not the best, but you don't have control over it. So you literally have 5 minutes in that room to do everything there is to do in that room. Okay, continue.
Yeah. And so again, because you have very limited time, you want to examine the very pertinent systems.
I will tell you the story of a patient I saw at my very early days in PGY1. That's in my first year, where I went to pick some unrelated findings as to why the patient came to the hospital, and I was so happy, and I presented it during rounds, and my attending was like, was that what brought the patient to the hospital? Apparently it's something that is in the chart that everyone knows. I didn't even know how to pre-chart to know that, so it's well known to them. So I boldly said, oh, I picked a diastolic memo that was radiate. We're like, gentlemen, is that what brought the patient to the hospital? Yeah, so very pertinent examination findings are extremely important in that room. Yeah. Okay.
And then there's also one thing that the listener should know, that these patients already have chronic comorbid medical conditions, like they have heart failure, they have liver disease, whatever you can think about, they do. And
10 diagnoses, at least 10 diagnoses
per patient, right? So you are dealing with exactly what exacerbated the patient's presentation to the hospital, right? That's what you want to think about, and then the rest are like secondary. I mean, unless of course it ties into your diagnosis.
Yeah.
But you examine the very pertinent the systems, and then you try and look at other things, but make sure you're not wasting so much time. So what I do is if this patient comes in with respiratory failure secondary to like maybe a heart failure exacerbation, what I'm looking out for is bipedal swelling, whether it's reducing. I'm listening to the heart, I'm listening to the chest, and then
examining the cardiopulmonary system.
That's all. Nothing. I mean, I wouldn't say nothing more, but like that is where I'll be paying more attention to, and then I'll just look at the abdomen and I go on.
The truth is that there are more sensitive diagnostic tools that can be used to pick changes in patient clinical status. So, whilst you have your Littmann stethoscope and you are very confident that you are going to pick a crackle, at a snap of a finger, they could order a chest X-ray, CT, whatever needs to be done. At that, I mean, sometimes I feel like it's
overkill.
Yeah,
sometimes.
But your physical examination findings actually come second, and that is the reality. So imagine you are spending so much time in that room, whilst at the long run they will do echo, they will do chest X-ray, a stat chest X-ray, and in 5 minutes it will be done. Like things that are changing the patient clinical status can easily be done in terms of diagnostics.
Yeah.
So just focus on what is relevant. It doesn't mean that you should not examine your patient. It doesn't mean that you should not.
I think that what you're saying is right. But then again, if you know the patient from like a day before, for example, you admitted the patient, you are going to do a full clinical exam. Right?
You have done a full clinical exam. Yeah.
Right. So you are coming the following day. What are you doing again?
So that's why you said that if something happened overnight, let's say the patient is requiring more oxygen than usual, then in your mind, is it fluid overload? Let me listen. Is it PE? Yeah. So based on what is going on, you want to just do a pertinent exam, and if it's not making sense, you definitely go ahead with the diagnostics. Even if it does make sense, like because of litigations and all those stuff, am I really missing something? You go ahead and order those diagnostic tests anyway. So the bottom line is, as an intern, maybe when you become a PGY2 or an attending, your approach will be totally different. But we are giving you survival tips or things that will make your life easier.
And make you more efficient.
Yeah, and make you more efficient. So just report to your senior that, hey, I'm seeing this patient who is more hypoxic or who is requiring more oxygen. I'm concerned for PE. Even before you precept with your senior, I'm concerned for PE. Can I go ahead and order a CTPE for this patient? That's a chest angiography specific to PE. You do not wait till you are precepting with your senior before you say, oh, when I went to see the patient in room 432283, he was requiring more oxygen. I think it's a PE. No, you don't do that. When you see patients that are not stable during your pre-rounding or at the time you are seeing a patient, you inform your senior about it, and that's, I think, is one of the take-home messages our audience needs to get. Another question I want to ask you is, so you have seen your patient, let's say you have seen your sickest patient, you now have the information in terms of what the patient tells you happened overnight, how the patient is feeling. Perhaps the patient say, okay, I'm feeling way better than I was yesterday. So you have that information. Now you are talking to me as your PGY2. Can you demonstrate maybe an example of a clinical scenario? Let's say you have a patient that came to the hospital with acute exacerbation of heart failure with reduced ejection fraction. So just demonstrate how you present that patient to me in terms of what happened overnight during your pre-charting, what you picked up, abnormal labs, what the nurses tell you, what the patient tells you, your examination findings today, and your plan for the patients.
Okay, so Mr. A, who is in 4322, presented yesterday on account of acute hypoxic respiratory failure secondary to HFrEF exacerbation.
What is HFrEF exacerbation?
Heart failure with reduced ejection fraction exacerbation. He is doing well today. There were no overnight events. He came in requiring like 4 liters of oxygen, now on 2 liters. Was diuresed with about 160 milligrams of Lasix yesterday and put out 2 liters of urine. So
net output of 2 liters.
Yeah, net output of 2 liters.
Okay, so minus 2 liters.
Minus 2 liters.
Okay.
So currently has no new complaints. On examination, his cause crackles way better than it was yesterday, and then he has resolving bipedal swelling. I did not see any JVDs. And he was saturating like 92% on oxygen, 2 liters of oxygen.
So from 4 liters to 2 liters now. Okay.
Yeah. So with his labs, his potassium was about 3.4, which has been repleted. Magnesium was about 1.5, which has also been repleted. It's on the potassium magnesium repletion protocol. So my plan for him today is to possibly diurese him again today, given that his blood pressures can hold, and then his creatinine did not really bump yesterday. Creatinine has been between 0.8 and then 1 since he came here, so we can re-diurese him today, monitor his urine output, monitor his electrolytes, and then possibly try to start him on GDMT.
What is GDMT?
Sorry, guideline directed medical therapy for heart failure with and reduced ejection fraction, and then possibly think about discharge planning in a day.
All right, so that's an excellent presentation by Beko as to what goes into presenting overnight patients or patients that have been seen by the intern to his or her residents during what we call pre-rounding. So if you can take your time to replay what Beko said, because he was a bit, he's now a boss, so you see how he was following. Yeah, it was a bit rushed. So Beko presented a patient who came with decompensated heart failure with reduced ejection fraction. Now, key elements of what he presented include the fact that the patient came requiring 4 liters of oxygen. So we know that there is a component of acute hypoxic respiratory failure, secondary to the decompensation of the heart failure with reduced ejection fraction. Now, patient has been diuresed with about 160 milligram of furosemide, and the most important thing that he mentioned was the fact that the patient responded to the diuresis by having a net output of minus 2,000 cc or minus 2 liters of fluid, which is very significant and which it's actually within the goal of what we expect to determine or to say that a patient is responsive or responding to the Lasix. Other thing that he mentioned is the fact that the patient can still tolerate more Lasix because the creatinine hasn't gone up or the creatinine level has not increased, which will have been an indication or an indicator that we are maybe over-diuresed the patients. And he has been able to tell the numbers of what the patient is requiring in terms of oxygen now from the 4 liters to 2 liters. Crackles are improving because he saw the patient the previous day and knew that the crackles were more significant than it is. So overall, this is a patient that is improving. This is a patient that we are all happy about. And one thing that he mentioned was that he has already introduced plan for discharge. And that is very significant. In fact, you should start planning at a point in your journey. I mean, after 6 months, you realize that discharge planning actually starts on the day of presentation. You already want to know. So as a second year, you want to know whether the patient is coming from home or not, whether the patient is coming from a nursing or rehab facility. You want to know where the patient will be going after discharge. Is he a patient that will be discharged home with home health care? It could be home nursing. We'll talk about all those nuances when physical therapy comes in, when case manager comes in. That will go into discharge planning. But what Beku demonstrated, you should go back and listen over and over. It will be the template, it will be what you'll be doing all throughout your life in residency, how to present patients concisely. I mean, if I gave him the opportunity, he would have even summarized it more, but he expanded it so that all components will be brought out to you. So now you mentioned what the patient came with, what we did to the patient, the fact that the patient responded to what we did. Labs were a bit abnormal, you have already repleted. And I mean, electrolyte management is one thing that you have to learn at a very early phase of your intern year, and your seniors will be happy with you when you are able to master how to replace electrolytes. So he's a good intern, so he has already repleted the magnesium and the potassium, and we'll talk later in maybe our subsequent videos when we are taking topics one after the other to tell you the relevance of why those numbers are important in dealing with patients. Is there anything I've left out in terms of your presentation that we need to explain? So we talked about the lab. Another thing that he could have talked about is the fact that maybe the echocardiogram that we ordered is still pending or has resulted. It shows whether an improved in this patient came with exacerbation, so it most likely will show a decrease in the previous ejection fraction, which used to be maybe 40% to 35% because the patient is not adherent to his or her medication. So Beku said he's starting this patient on guideline-directed medical therapy, which is actually a standardized medication that every patient with heart failure should be on. And Beku mentioned that he believed strongly that the patient's blood pressure will tolerate. These are languages that you learn when you start residency. It comes with time. You start singing it, you start echoing it without even knowing. I mean, when you start, people will be saying it and you think that they are speaking Swahili or a foreign language. With time,
especially when you have a problem. And we should talk about this soap format thing in another video. But
the soap format, it's going to be a whole video.
Especially when you have this problem. For the first time I heard someone say etiology is multifactorial. I'm like, what is this? You see?
It's a language, and it's spoken all throughout the United States. Every residency program almost always has the same format. It's universal. So I mean, your friends in New York are speaking the same language. Your friends in Georgia are speaking the same language. It's universal and it's beautiful. So when you are talking to your colleagues in other programs, it's like you're all speaking the same language. It's the same training everywhere. It's beautiful. And with time, when you record yourself and listen to yourself, you'll be like, oh,
you've made progress.
Yes.
So much progress,
So it gets better. We'll keep telling you that it gets better. The importance or the essence of this video is for you to play it back to yourself when you start this journey and know that we have said it before that things will be difficult from the beginning, but it only gets better. So we have gotten to the part where you have presented the patient to your second year. So I'm assuming I'm your second year. I'm going to poke a hole in your in your presentation, or try to ask you a few clarifying questions as to things that needs to be done for this patient, so that we'll be prepared enough for our attending. And rounds, of course, will be starting in 15 minutes. So I hope you have your other stuff ready. Okay, so regarding Mr. A that you presented, was he using Lasix at home already? Is he Lasix naive?
No, he's not Lasix naive. That's why we started him on 160. He uses 80 milligrams Lasix at home. And so
he uses 80 milligrams?
Yes, 80 milligrams of Lasix.
Okay, so he's not Lasix naive.
He's not Lasix naive, yes.
But are you sure he's been taking it? Why do you think? Because we need to know why you went into decompensation.
Yeah, at this point, could be medication and adherence versus just dietary indiscretions. Last time I spoke to him, he told me that he hasn't been adherent to his 2 gram salt restriction, and he's been taking out of fluids, and he binge ate a few days ago. So all of these things could be contributory.
I mean, we do not need to anchor. We need to take more history and find out if there is any other thing that could be leading to his.
Yeah. And he also has a remote history of atrial fibrillation, so maybe that could have.
When he came, was he in atrial fibrillation?
No.
Okay,
but again,
we can't make a case for atrial fibrillation. What other thing can you think of?
For reduced ejection fraction and exacerbation, we can think of other things like we could talk about infections. Like,
do you think this patient has any infection? Are you concerned for pneumonia?
Upper respiratory tract infection for the past 2 weeks. Yeah, he mentioned that he had an RSV infection, maybe could cause, but of course, a subtle myocarditis, which could have tipped him into an exacerbation. That's true.
But that's 2 weeks ago. I mean, and he came overnight, so. Yeah. So what we are trying to do here is your PGY2 will not be satisfied with you having just one reason to define or to explain a problem as to why the patient came with the acute, in this context, why the patient came with acute exacerbation of the heart failure. You want to not anchor on just one etiology. He alluded to the fact that when he started, he had etiology like him multifactorial, and that's what we do as often as possible, because it gives you the room to explore or think broadly as to the multiple etiologies that will be resulting in just a problem. So in this context, it could be that the patient was not adherent to his home Lasix. It could be due to the dietary indiscretion, like he rightly said. The patient is not adhering to the amount of fluid and salt that he needs to be taking daily. It could be infection. It could be that the patient has paroxysmal atrial fibrillation that actually resolved by the time the patient came to the hospital. A number of things could have resulted in why the patient is presenting, and as much as possible, if something is not making sense, they expect you, the intern, to be the detective, going back to the bedside to ask the patient all the necessary questions that is needed to unravel the mystery.
Alex, you know, there was this patient I had a while back. You know what exacerbated her heart failure?
No.
Anxiety.
Anxiety.
So she just had what's it called? She got anxious over binge buying certain things, and then she started really hyperventilating, and all that sympathetic drive just worsened the heart failure. So many things.
And how did you get to know that it was anxiety?
Just because of the history.
You went back.
I went back to ask questions.
Yeah. So
you need to ask.
Going back to the bedside, and that makes it very difficult because you have limited time. Things are not making sense, and that's what makes intern year tough, because everyone expects you to be the first contact with the patient, and they actually make you first contact on the EPIC system. Maybe it may differ from other programs, but here you have the opportunity to make yourself the first contact of the patient. So every message from the nurses comes to you. Every question about the patient, you are supposed to be the spokesperson of the patient, so far as the patient is on admission. So going back to the patient to ask what we call clarifying question is really, really important, because on rounds, if you do not have a reason for each problem that a patient has whilst on admission, you are going to be hot.
Yeah, very hot.
And there's a reason why they call it problem list. And when we get to the SOAP note format as to how presentations are made, you understand all this. But patients are assessed by their problems. I mean, and it goes to billing and all those complexities that we'll talk about later. But at the end of the day, the bottom line is know your patient, be willing to go back to the bedside. The fact that you have seen the patient at time A doesn't mean that at time B you are not supposed to go back and gather more information if it becomes necessary. So, Dr. Beck, we'll go back to the patient that you just presented. Now, we have presented this patient on rounds. The attending is okay or happy with our plan. We are going to diurese this patient further, hoping the output is, significant. Hoping we meet our next target of maybe still the -2 liters, and then hopefully discharge this patient home the next day. Let's talk about the multidisciplinary team that comes to play in management of this patient. The nurses, the physical and occupational therapy, the case manager, the charge nurse, the wound care if the patient does have a wound somewhere. All this, are they relevant? What's their role in management of this patient and in discharge planning?
Okay, so this is something that I struggled with in the beginning because coming from my background, you in fact in Ghana you never see things like this. Like you never see wound care, you not see a case manager and like a charge nurse and all of those people like working together to make sure this patient is getting better, actively doing it, right? So number one, if you have what is a case manager? A case manager is like a social worker, and you see back home in Ghana, you don't even know what roles the social workers play. It's not really clear cut, right? But this is someone who actually helps you set up the disposition for the patient and takes care of other things. I was surprised that patients could actually ask social workers for clothes, financial aid, even food. They do all of that for these patients. So it's like, I would say that the social workers are like, the case managers are like the patient's mothers in the hospital. I would say something like that. They are the ones who
patient advocates.
Like they are the ones who would help you know where this patient is going to, what this patient needs. Going home, there are some patients who won't be able to walk at home after the hospitalization, so they will tell you maybe they need a rollator, like a walker or something.
Good.
These are the things that the case managers do.
So I think, to summarize it all, to put it in a different way, they take their own personal history. When a patient comes to the hospital, the social worker or the case manager goes to the patient, and sometimes, and this is one trick, I go back to their notes to still very relevant information from their notes. They ask the patient where the patient lives. They ask what we call social determinants of health, things that defines the patient's well-being, the patient educational status, transportation. Think about it, where the patient lives, who the patient lives with, all those relevant questions. Patient pharmacy, who the patient primary care doctor is, where the patient will be going, whether the patient will need special equipment or what we call durable medical equipment, like he mentioned, the patient insurance status, whether the patient will be able to afford the necessary medications that will be prescribed for this patient. So they are very, very crucial in the management and discharge planning of the patient, and you can actually not discharge a patient without them. Yeah. So that's about case management or social worker. Let's talk about the nurses. Do they fold their arms?
What? Fold their arms? No, I've never seen a nurse fold their arms. Like, they are always on the move. Always on the move. If they're not beside the patients, they're checking charts, and they are even prompting you to check some labs because some labs have resulted. They can prompt you to check imaging results because they resulted, and then they are so crucial that they can actually, because they are at the bedside and they are seeing what's going on, they can actually advocate for the patients and ask you to perhaps
come and see the patient,
do something for the patient there and then. Even with your prescriptions and then all the medications you write for the patients, they can actually ask questions and be like, well,
that's the beautiful part. You know, we are used to the system in Ghana where, when in most hospitals, at least where I have practiced, when you churn out a prescription to a patient, no one questions you, no one asks you why this and not this. But here, we'll talk about, even, I forgot to mention pharmacy.
Hey,
even before pharmacy decides on the prescription, it has to be like evidence-based. The patient's weight, the patient kidney function, the patient liver function, they will have checked all those. And I came here to appreciate the role pharmacy play in management of patients. They are the ones in charge of prescription. They are the one in charge of dispensing the medication. They are the one who determines whether the patient received the medication or not. And you must both come to a consensus and say, okay, this is what is best for the patient, so we are going to give this to the patient. And if what you are giving to the patient is not really the routine medication or the routine dosage, you have to justify why you are doing it. And they are very supportive in that regard. There are times that you need to call them and get their mind on certain prescriptions that you make, and they will do all the work for you. They will research the guideline and tell you that, hey, according to this and this guideline, in the context of your patient clinical scenario, this is what we think will be best for the patient. Then you go ahead. So very useful resources we have, and I couldn't have asked for more. When I got to know that pharmacy can actually help, I think I've been abusing that.
You have? Yeah. I think I should abuse them too.
Yeah, they do all the work for you.
Yeah.
Sometimes you just put in the prescription there. I mean, this not kind of recommended because it's a shortcut. You put the prescription there and say pharmacy to help with dosage. Then it goes directly to them.
Yeah. Or defer to RPH.
Yes. they will do everything for you.
Mm-hmm.
Yeah.
They dose and all of that.
So that's about pharmacy. The nurses, you started saying how very crucial they are in advocating for the patient. Mm-hmm. When they say come to the bedside, please go. They know what they are saying. I mean, sometimes it gets overwhelming because as an intern you have a lot going on, and the nurse, please prompt your senior, prompt your PGY2, prompt your PGY3 that you think there is something going on. The nurse wants one of you to come to the bedside. Usually they will send you a secure chat because you are the first contact. Mm-hmm. Add your senior resident to that chat. They usually will follow up on those ways, because you can't do everything. As an intern, you are the one writing the notes, and that takes a lot of time. So if you want to focus on other things, it's very difficult. So you have to find a way to delegate things to your seniors, and adding them to those conversations to take care of those bedside staffs is very important. You can continue.
You just mentioned notes. Code notes.
Oh. It's because of note that I would never miss my intern year.
No, you see,
that's the most difficult part.
I realized that I didn't know this, but the more I work here, the more I realize that you spend 95% of your time on notes and the documentations and the computer, and your notes should make sense. You know, back home in Ghana, you just scribble something and write CT and that's it.
CTRS, continuous treatment.
My God.
The diagnosis, a triangle.
Hey, bro, can you write CTRX here? What is that?
I've actually not seen CTRX before. No, it's not one of the jargon that is used here.
No.
I mean, even the consultant, the attendants
are writing notes.
Notes that, because the billing department, and this is very significant. The billing department, most of them are not doctors, nurses. They are not healthcare professionals. So you need to communicate to them through your notes. So they use those information to bill the patient. So if you are writing CTRX, triangle, and diagnosis, and things that do not correspond to the ICD-10 codes, no one knows what is going on. And that's why writing notes, it's so crucial, and it said 99.
Yeah. of your time.
Yeah, as an intern, you spend all your time writing notes, and your attendings, your seniors will make sure that you put in a good note, because it communicates to the nurses, it communicates to pharmacy, it communicates to the billing department.
Everybody reads
it's
your
a
notes.
legal document.
Everybody reads your notes.
Most importantly. So
yeah.
I don't miss writing notes.
And you know what even shocked me the most about note writing? The fact that everything has a severity.
Yeah.
You know, like you write we'll talk about this later, but you write a problem, you're looking at the etiology and then the severity, and then you're looking at other things which could not be the reason why you're having that problem, and then you look at a plan. So it's very, very, it's an intense.
A lot of thinking goes, and especially if it's your first time. I mean, if you're admitting the patient and you don't know what to explain the patient's problem or symptom, then you want to, for instance, let's just take it that a patient came with fever, chills, leukocytosis. So now you know that there's an ongoing infection. But where is the source of the infection? So now, is it respiratory? Is it urinary tract? Is it GI? Is it the skin? Is it CNS? So you are now explaining, you don't think it's this because this and this symptoms are not there. You don't think it's this. The good thing is that the next day, when you finally narrow down to what it is, let's say it's pneumonia, you wouldn't go writing all those. You don't think it's this and this. But that initial moments where you are seeing the patients and trying to figure out what is going on, it can be so intense that because someone will take your note and ask himself or herself, has this been ruled out yet? But if you communicate that, hey, I thought of this, but I do not think it is because this and this are not there, and imaging did not support it, then everyone knows that, okay, this person has already ruled out this. So that's what makes it so intense. I think, Anna, what we are used to is so diagnosis, and then it's the format is totally different, and I'm already beginning to forget what we do back home.
I don't. Let me see. So if the patient will present with maybe difficulty breathing, and then you do your examination findings, and you hear crackles, and then you figure out maybe with a fever, crackles.
So you say it's pneumonia, and that is it. But here,
it's not like
if the patient is hypoxic at any point in time, then the ICD code that you need to put in there for the right billing is acute hypoxic respiratory failure, secondary to, if you are very confident it's pneumonia, fine, secondary to pneumonia. If you are not confident, then the etiologies. And the thing is, patients here have so many comorbidities, and because their medications or their healthcare is good to sustain them, so they are living long with all these comorbidities. Ghana, for instance, if you have 2 or 3 and you are not adherent to your medication, you have died. So you won't come with 10 problems, right? So you have patients who have 10 medical problems that could explain why they are coming with acute hypoxic respiratory failure, because they have heart failure. Perhaps they are not taking their medication, so they are in acute exacerbation. But they are coming with fever and chills, so you think that, okay, maybe pneumonia is playing a role. They are in a assisted living facility with some bed sores there, so you think that, hey, the skin could have contributed to it. So it makes the whole thing so complicated. They have COPD, so you think that the COPD exacerbation is contributing to it. That same patient has atrial fibrillation, and because of all the stress going on from the infection, is going into AFib with rapid ventricular response. So that will also explain. So
same patient has end-stage kidney disease.
That same patient has end-stage kidney disease and could have gone into fluid overload. That could drive all. So which of this is contributing to the patient problem? It could be any of them, and that's where the anthem etiology is likely multifactorial comes in, that you will be singing soon when you start your residency. And those problems comes with their corresponding medication, and that alone, it's totally, it's totally different thing altogether. So use the opportunity to just talk briefly about medication reconciliation, your experience with medication reconciliation.
Bro, the very first time I was looking at medications, I was hit with Brilinta, and then Fioricet. And then I'm like, what is this?
What is this?
Meanwhile, it's just what? I mean, very, very simple. Here we use lots of brand names.
Oh, the brand names.
Brand names. They just keep hitting with brand names. Meanwhile, if you look it up, it's just like a clopidogrel or like an aspirin or like a bumetanide or something.
Clopidogrel, instead of them to say clopidogrel, they will say Plavix.
Instead of them to say Tecabrel, they will say Brilinta.
Yeah.
Right. So it's something that I really still have to look up the drug names because I'm still not used to. I mean, the common ones.
Did I tell you my first day on the floor? My senior asked me, "Is this patient on GDMT?" And I was like, "Which medication is that?" and he looked at me in a certain way. I was like, so I quickly checked, and here they expect you to quickly check things up if you don't know. So,
yes.
Ghana, we want to have everything in our head to prove that we know and all those stuff. No, here everyone understands that there is so much information. So on the go, you have to
be checking
and looking things up to make sure that you are double checking and doing the right thing. So I quickly checked. He looked at me in a certain way, meaning you could have checked this. So I realized that okay, so GDMT actually stands for guideline directed medical therapy, and what he's asking me was basically, is this patient on the right medication for his heart failure? And I mean, you are not supposed to use abbreviations to start with, especially for someone who is like me, but because it has become a second nature, because it's something that we all do. I'm now guilty of it because I've now learned the language and I use it every time.
Look at me saying GDMT.
You see?
So
with time you begin to sing the chorus of what is the routine here and get used to it. But when you start, you be so mad they are using abbreviations and using brand names and things that you don't understand. And Tresto, Jardians, and all.
God. Yeah.
They are brand names, and some of them are just brand names in America. So how do you expect me to know what Lovenox is? Whilst in Ghana, I know it as Clexane. Yeah. So medication reconciliation, it's something that you have to take time and master. It's also going to be a whole topic on its own, how to tell whether the patient is taking it. Fortunately, in our hospital, there is a dedicated nurse called the MedRec nurse, which is medication reconciliation nurse. So you can imagine, it's such a big thing that a nurse has to be dedicated to do the medication reconciliation. They cross-check the dispensing pharmacy that dispenses the medication. When it was last dispensed, they ask the patient or patient relative how the patient is taking it and reconcile it with reconcile what the patient is doing with what is on the patient chart, because maybe 2 weeks ago the patient is taking it differently and the primary care doctor changed it to a different dose because of a certain adverse effect. So just imagine one patient with 10 medical problems, with 10 medication that need medication reconciliation, that needs how do we call it, reconciling those 10 problems to his or her clinical presentation, calling. And most of our patient population are older adults. So some of them, when they come, they may be in delirium and you have to call their relative, update their relative. A whole lot go into the management process. So it's not surprising that Beck, who woke up at 5 a.m. and even at 7 a.m., he wasn't able to see 4 patients, right? Yeah. Meanwhile, at Suhum, I'm sure if they give you 70 patients, you have cleared them all.
This guy. But
so, I mean, those are the realities. There is a lot to talk about, and if we want to capture everything in this video, it may take up to 5 hours.
Yeah.
So I think we've touched on the very important points as to what you expect on your first day, perhaps first week on the ward in the ICU when you start your residency as an international medical graduate. The challenges with presentation, your low confidence, not knowing what is going on, not knowing the language being spoken just because everything is new, the brand names are over your head, the nurses and what they expect from you. Sometimes they will use a term. I mean, they communicate with residents over the years, so they expect that, okay, I mean, they are not as conscious of your presence as an intern. They feel like, okay, you've been to medical school and then you know certain terms, so they may use terms that you are not familiar with. Sometimes they send a message and you don't know what to respond to. You just need to add your senior to that chat, but sometimes your senior too is extremely busy and cannot respond on time. So it will be overwhelming, but the message that we wish to communicate is it gets better and better. So do not be intimidated by any of this that we are saying. Well, that is not the aim of this video. We just want to inform you. We just want to prompt you as to what to expect and encourage you that it actually gets better. Any last words?
Well, you just reminded me there was this one time the nurse was like ANO times 3. And I looked around and I was like,
what is that?
What is ANO times 3? It's just alerting oriented times 3.
Yeah.
So, I mean, you'll hear a lot of things. This is not supposed to intimidate you. It's just supposed to actually give you like what happens on the ground. And you're just trying to be very, very realistic with you, you know. But then again, it's a steep slope. You know, we are coming from different places, different kind of trainings and all of that. But then you realize that as you kind of progress in the program, everything just levels out, and then you'll be extremely comfortable. I'm still finding it difficult doing certain things, you know, but
yeah,
it's
I mean, throughout your residency journey, at least from my seniors who completed, you realize that you will never be ready as an attending before you complete. Even the attendants do not feel ready. There are attendants that are still learning how to navigate EPIC. That is the electronic medical record that we widely use. So don't be too hard on yourself. I think the best thing would be to maybe have some practical sessions or demonstrations to at least cut out patient identity and demonstrate how some of this, how to navigate EPIC in general. At least that's I don't think it will be extremely helpful, but it gives everyone the idea of what to expect, and they will be less nervous perhaps when they start. So that's something that we can do to help our colleagues who will be joining us soon or who intend to pursue their residency in the nearest future here. Yeah. My experience is not totally different from Berko's experience. My first patient I saw was a patient with COPD exacerbation, and when I got to the patient room, I mean, I know what COPD is, but trust me, I didn't know what to do. I was just looking at the patient. I didn't know that I'm supposed to ask the patient code status, which basically is to say that whether the patient will want to be intubated or resuscitated if it's indicated, and that you need to know before you even admit or you are able to bypass the admission process in a patient into the electronic medical record. So all those things are very system-based stuff that someone needs to hold your hand, and if you have a good senior, I think it helps. Like if your senior is patient, if your senior have that empathy, like there are times that the senior especially your second year, is now learning to be a second year. So it's overwhelming for your second year, right? And then you're also learning to be a new intern. So everyone is stressed, everyone is kind of frustrated. So if you have someone who is patient, who understands, it goes a long way to help.
Yeah. You just reminded me the very first time I was seeing my very first patient, like an admission. I didn't know what to do. Like, you have all the knowledge, in your head. You don't even know. You get so scared asking questions. You get intimidated because it's a whole new system. You have people watching you. You have a patient looking at you in a certain way.
Yeah.
It's like, it's just.
Yeah.
But then again, it gets better. That is all we are just trying to say. It gets better. It's not. Don't be too hard on yourself when you feel intimidated the first few days. I mean, it's something that happens to almost everybody, almost every IMG. I even think the AMGs to go through this.
Yeah, I mean, their story is a bit different because during medical school, they have the exposure, but trust me, when they start residency, from what I heard or from what colleagues who are IMGs tells me, they equally struggle, only that theirs is relatively better because they are used to the soap format. They are so confident, oh God, when they are presenting on rounds, like the flow, the communication, it's totally different, and you realize that, okay, these are people who have been in the system for long, and that really makes the difference. But we all struggle, IMG struggle, AMG struggle, and it's not exclusive to just IMG. So yeah, I think time will not permit us to touch on everything. We'll bring today's episode to an end. I think in our next video we'll touch on a very important subject, and that is, in all this we mentioned how there is multidisciplinary approach to management of patients, where different professionals or healthcare professionals come into play. What we did not touch on is the specialists, the consultants. When do you consult them? How do you consult them? The timing is very important. What you tell them is very important. So in our next episode, we'll touch on how to call a good consult.
Yeah, that will be a good one.
How to call a good consult and not be yelled at. So that's we'll touch on in our next video. Thanks so much for watching. Kindly subscribe to our channel, support the channel, spread it, share it with colleagues who are not even planning to come to the US. I think even if you are practicing in your country, there are a thing or two you can learn from this video. So until we meet again.